Hey guys, this is Aaron Brocious for the last time for this class. This is my final project, my final presentation for the Johnson Community College Instructor Methodology course. So my topic and what we'll be talking about today is going to be predominantly, specifically pre-hospital blood administration, but we will talk a little bit about some of the history of just blood transfusions and blood products, just in general, and then talk a little bit more into the specifics of pre-hospital administration. So unfortunately, we couldn't teach this class in person like we were supposed to, which I guess, quite frankly, would have been easier for me. It's what I'm more comfortable with, but I've really learned a lot of this kind of using the screen web camera, uploading videos, things like that. So it's been a good educational for me outside of just teaching a class. So we'll kind of just jump right into this here. So just real briefly, I have no financial disclosures, anything like that. There'll be a couple products that we talk about throughout this presentation, but I'm not being paid. These are strictly my opinions. I'm not saying one product is better than any other, just giving you some examples here. So our objectives for this class, we're going to briefly talk about the history of just blood transfusions and blood product administration. We're going to talk about the products that are available and kind of how they're stored and when we might use one versus the other. Then we'll look into a little more pre-hospitally specific about some areas and situations, indications where we might consider pre-hospital blood administration and kind of the process of how we would do that. And then lastly, we're going to end with my skills demonstration video talking about just the process of administering blood, the equipment that we would need, and just kind of the step-by-step process of administering that product. Okay? So without further ado, we'll jump right into it here. And we're going to talk a little bit about the history. Now, I'm not going to read all of these word for word to you. You guys can read all of this and pause it if you need to. But you can see there, 1665 was the first recorded success of blood transfusions between dogs. And so that was, America itself was not even a thought yet, but, a lot of this was happening in England. America was just first getting settled. So this is, centuries ago. And they started, like most science happens, it started practicing on animals. We can see here in 1795 that the first successful human-to-human transfusion happened, and this was after the Revolutionary War. This happened in Philadelphia. As we continue on through history, again, you had United States, Europe was starting to do a lot of research on here. So this one kind of blew my mind, and as I was doing this research, I had never heard of this. But here, 1873 to around 1880, so this was a period of almost 7 years that U.S. surgeons were actually using milk, human, cow, and goat milk to replace blood loss. I would really be interested to see what that actually did for the patient and how the patients responded to that. I haven't done an in-depth research into that, but I thought that was actually fascinating. I had never heard of that. So, but it didn't last too long. So we see here in 1884 that milk was finally replaced by saline as a blood substitute due to adverse reactions. Again, kind of curious what those adverse reactions might be, but very, very interesting. So, but another thought that I kind of had as I was doing this, so we see all the way back to 1884. This is almost 140 years ago that we started using saline to replace blood. And here we are 140 years later with all the advances that we've made in medicine. And quite frankly, for most of us, that's exactly what we're still using. We're still using saline or water to replace blood. And hopefully as we kind of work through this presentation, you'll see why maybe that's not always the best thing for our patients and that there are other options out there that hopefully we can maybe in the future of EMS start seeing used. So there in 1916, that's actually during World War I, we start seeing the use of blood banks, or blood depots as they were called at the time, where they would store blood from donors to be used on the battlefields to treat these injured soldiers. So as we kind of continue up through there, in the 1930s into 1940, we actually see the discovery of the RH. So up until that point, we just had the A, B, O, and AB type blood, but didn't realize until actually almost about 40 years after it was first discovered that there was this RH factor that was causing some other reactions in patients. And so that started getting studied a little more, and started determining, what blood can be used on what people. So in 1950, we see that plastic storage bags replaced glass bottles, which was huge for the military and for pre-hospital administration. And then we could see it kind of start moving into, the HEMS being helicopter EMS. We start seeing it used in the military again. It kind of had gone away and come back a lot like tourniquets have even. And we'll talk a little bit more about that walking blood bank right here. And 2016, 2018, we start seeing actual blood products, including whole blood, just 2 years ago, carried by ground EMS services. That's pretty exciting, and I hope, and I really do hope, that in my career we can start seeing more of that happen in EMS, because it is important and it saves lives. So just briefly, we'll talk about the types of blood. Most of us are pretty familiar. We've got all the way from O negative to AB positive. So our blood groups are AB, B, A, and then O. And then the positive and negative here dictates whether they have that RH factor or not. So as most of us are aware, that type O negative is the universal blood type. They're the universal donor. They can give blood. O can be given to anybody, and since they're O negative and it has no RH factor, it can be given to any of these other blood types. Okay. The opposite side of that is we have the type AB positive, which is all the way down here at the end, and that's the universal recipient. So they can get blood from any of these, but unfortunately can only give it to themselves. A little more selfish, if you will. So I'm actually an A negative. I know a lot of us probably don't even know our own blood type, but I actually am A negative. So I kind of sit right here in the middle, but I can really only receive from O negative or A negative over here. So just kind of interesting little chart, just showing you what blood products or blood groups can be given to others. We'll talk a little bit more about that as we go here. So this is just an interesting chart looking at the actual blood type distribution, so amongst different races. So as we can see, the most common blood type across any race or ethnicity is O positive, and that's anywhere from 37% all the way up to 53%. So going down to the most rare, which is AB blood type in general, but AB negative is really the most rare. That's anywhere from 0.1% to 1% of the population. So and then everyone else is a little kind of in between there. So here I am, I'm a Caucasian, so A negative. There's about 7% of us running around out there with A negative blood. So kind of interesting, and you can just see as we go even across to different ethnicities and races that it's actually A negative is a lot less common in non-Caucasian races. So it's just kind of interesting how that distribution is. And it's something that, as doctors and researchers study blood, that kind of has to be taken into consideration for these blood products. There's another chart kind of showing the distribution of blood, specifically in the United States. And they actually have these charts for all kinds of, for every continent, every country. And it is interesting how they differ. And again, it's based on race and ethnicity in these other countries. So as we move past those blood types, we're going to look at now into the different products that we carry. So this was a pretty neat picture, just showing kind of how we take this whole blood product here and break it down into these other products. And so we're going to talk about packed red blood cells, fresh frozen plasma. We're not really going to get into cryoprecipitate too much. That'd be another topic, and that's really not anything that's ever used pre-hospitally. And then we'll talk a little bit about platelets. Again, generally not used in the pre-hospital environment, but it is a common blood product that we will talk a little bit about. And then finally, we'll talk about whole blood, which is newer, somewhat controversial right now, but I think will be what we start seeing more and more of in the future. So whole blood, some of the benefits of it, it's got everything that we need. It's what is running through your body right now. I had an instructor tell me one time when we were talking about trauma, he said, if you were, choose your favorite drink, whether it's a Coke or a beer or whatever, and if you drink half of it or half of it spills out onto the floor and you want to refill it, are you going to refill it with water or are you going to refill it with more of the same beverage? Well, the obvious answer, most of us don't want watered down soda or watered down beer. You're going to refill it with whatever you lost. And why don't we look at the body the same way? If the body is losing blood, ultimately we need to put blood back into it. So whole blood is just kind of the best of all of those worlds. We have that oxygen carrying capacity of the blood cells. We have that volume and clotting factors from the plasma and the platelets. And we can see here that it can actually be refrigerated for up to 35 days, which is a pretty good shelf life, just considering some of the other products. And that's kind of a newer thing. For a long time, whole blood could not be stored for very long at all. So we're seeing shelf lives increasing for this whole blood. And it's pretty exciting to see how that can start translating into our world in pre-hospital environment. So another product that we have, probably the most common, what we see a lot of times hung in the ED and things like that is packed red blood cells, or PRBCs. So these packed red cells obviously have an oxygen carrying capacity. They have hemoglobin, and so they can carry oxygen. What they don't contain a lot of times is any type of clotting factors or a lot of volume. There is some volume in it, but it doesn't increase the overall volume very well. It just increases the patient's ability to carry blood and oxygenate the body, which is obviously important. So one of the downsides to PRBCs is actually the citrate that is used to store them to help keep them from clotting in the bag. It actually is an anticoagulant. So when we give large amounts of, especially PRBCs in some of these blood products, we're actually putting large amounts of anticoagulants into our patients. And obviously these patients most of the time are needing blood because they're bleeding out. So we have to kind of counteract all these anticoagulants that are in the blood products for storage and give some medication. Generally, that one of those is calcium chloride or calcium gluconate can actually help break down the citrate that is in the blood products and can help allow the clotting to take place appropriately. So as we can see there, it can be refrigerated anywhere, 2 to 6 degrees Celsius for up to 42 days. So that's why it's very common, especially pre-hospitally, because it has the longest shelf life and doesn't have to be changed out quite as frequently. So next up, we have plasma. So plasma is something that we're starting to see more and more of, and there's 2 common types of plasma that we see out there. So what plasma is it contains volume, it contains some coagulation and clotting factors, has albumin, which will help stop that leaking from blood vessels. And it comes in 2 different varieties. So we have the fresh frozen plasma, which is what we see down here. It comes in a bag like most blood products that we're used to. It's generally yellow in color. And it has a shelf life once, if it's frozen, for up to a year, and once it's thawed for a day to 60 hours. The other option that we have, as we can see on the picture on the right, is freeze-dried plasma. So that actually has to be reconstituted. So we can see where, I don't know if you could see, but there's some powder in here. So it's actually a powder that you then mix with this sterile solution, and it can be stored dry for up to 2 years. And so the military is going real heavy into using the plasma, the freeze-dried plasma, because they can carry it in the field without having to refrigerate it and then just reconstitute it. And so it's becoming very, very prominent in the military settings, and we're starting to see it more on helicopters and in the pre-hospital environment because, again, it doesn't require that refrigeration. So when they're in the field or in an ambulance or helicopter, it's much easier to store. And then you have still 4 hours once it's reconstituted to use it. So really good product, something that is kind of exciting to see where it's going to go in the future. And then here we have some platelets. So platelets contains those clotting factors that are in the blood. Not a lot of volume is going to be in the platelets. Generally, they're only used in hospitals. As we can see in this picture here, this is an agitator. And so they have to continuously be agitated because of those clotting factors in it. They can start coagulating and clotting very quickly, and they're very susceptible to bacterial contamination. So they have to be continuously agitated, and even then their shelf life is only about 5 to 7 days. So pretty short compared to whole blood, PRBCs, and the plasma. So that's why we kind of see that more in the hospital setting and less in the pre-hospital setting. Here's my sweet animation for agitating the platelets. So predominantly, so this, as a disclosure, was actually primarily taken from the Committee for Tactical Combat Casualty Care, but this is also for the Committee of Surgeons, the American Committee of Surgeons and Advanced Trauma Life Support, the preferred products for resuscitation of hemorrhagic shock in these patients that are bleeding out. So as we can see, best thing that we can give them is whole blood. It's got everything that we need. So the next best thing, we move into plasma, packed red blood cells, platelets, given in a 1-to-1-to-1 ratio. So in a sense, we're giving whole blood. It's just now it's in 3 different bags. We have to go through different IV lines, and it just becomes more difficult. But maybe we don't have whole blood, and it's the next best thing. Lastly, we got plasma and packed red blood cells in a 1-to-1 ratio. Then we have freeze-dried plasma if we don't have any other blood products. And then we can come into either liquid or thawed plasma or PRBCs by themselves. And then lastly, and this is where most of us live, is crystalloids. So we're familiar more with lactated ringers, saline, maybe plasma-light. Hexten was used in the military for a long time. But those are not always our preferred products, but they are generally what we have to use. So here's just a little look at the difference between if we give 1-to-1-to-1 versus just giving whole blood. So this has a little more volume here than the 500 mLs, but we can see that the hematocrit in whole blood, the platelets in whole blood, the coagulation factors is all better when that blood is just kept as a single unit, as whole blood. And this is just another slide kind of showing again the same examples. So what are some indications for blood product administration? So most protocols, both in ground EMS and helicopter, for traumatic injuries, it's what we're used to, either penetrating or traumatic injury. And then for certain medical patients, it's that gastrointestinal hemorrhage, maybe postpartum hemorrhage, and then certain post-surgical patients. A lot of times we'll see those in the critical care transport side. So these patients, if they meet one of those categories and then they fall into one of these sections here, so if it's an adult 12 and older, we're generally looking for a heart rate greater than 120, a systolic blood pressure of less than 90. If we can and we have the ability to check hemoglobin, we're looking for hemoglobin of less than 7. So primarily when we're looking at medical patients before administering blood products, we can look at that hemoglobin if we can assess that with an I-stat, labs at the hospital prior to transport, something like that. So with pediatrics, similar, it's just obviously with peds, we know their vital signs are different. So we're looking at a heart rate greater than 150 and a systolic blood pressure of greater than 70 plus the child's age in years times 2, okay? So administration, I'm not going to get too into the weeds with this during this presentation because we'll actually talk about this in my video at the end. So, but just a couple things to remember. We want to get that baseline set of vital signs early before we start administering any products, because that's what we're going to use to trend, is the patient having a negative reaction to the blood. Another important thing to remember is that we want our IV catheter to be at least a 20 gauge or larger, okay? So when the smaller gauges, it can actually hemolyze that blood as it goes through those smaller 22, 24 gauge catheters, all right? So now with peds, I know that can be a difficult thing. So, and another important thing to remember is that we want to keep that fluid warm, okay? We want to run it through a fluid warmer. Most of these products are kept cold. They're refrigerated or frozen. So we need to warm them, because if we start putting cold fluid into our, hypotensive, hemorrhagic patient, we're just going to start making this even worse. We're kind of negating any benefit that we would give with the blood, because as most of us are familiar with, cold blood doesn't clot. So the equipment that we'll need, and we'll talk a little bit more about, but we're going to need some saline, 1 unit of blood or whatever blood product we're administering, blood tubing, that wide tubing, a fluid warmer, and then potentially a pressure bag, depending on if we want to put that in quickly. So we're familiar with the 6 rights of medication administration. Here's the 8 rights of blood administration. So we've got right product, right patient, right dose, right time, right reason, right site, right documentation, and the right response. Are they responding appropriately to this blood administration? Again, we'll look a little more in depth at this during the video, but this is the basic setup. So we have that Y tubing and saline on one side, blood product on the other. We want to have that filter and our drip chamber. Something to keep in mind with that. So one of the reasons that we do not use LR, so LR actually contains calcium, which could be a good thing in the body to help promote clotting, but in the bag, we don't want this blood clotting in the filter or in the line, okay? So saline does not have calcium. It's not going to promote any clotting in this blood tubing, okay? And then this is an example of a fluid warmer that is pretty common. It's called the Buddy Light. There's many other types of fluid warmers out there, but this is an inline warmer. You could just hook your saline up to it and then hook it up to the patient, and it will actually warm the blood up to 98 to 100 plus degrees very, very quickly. Pretty impressive piece of equipment. So, and it's very important for when we're administering these products. So I know I kind of went through that process a little quickly, but we're going to go more in depth in the video with that. So then briefly, we'll just talk about what massive transfusion protocol is. So that'd be greater than 4 units of PRBCs over 1 hour, greater than 10 units of PRBCs over a 24-hour period, or just basically replacing the patient's total blood volume one complete time. So, which is obviously quite a bit of fluid. So this is, like we mentioned, where we may require some calcium, because that citrate that's used to preserve the blood products, it can break down and decrease patient serum calcium, and that actually can affect the way that they clot. And this was kind of just a fun factoid that maybe you guys are not familiar with, that I just think is very, very fascinating. So the military has been doing these studies and trials with what they call walking blood banks. So this actually started in the 75th Ranger Regiment. Everybody that comes into the unit, their blood is typed. They know who all has what blood types. And if someone is injured in the field, they can actually go ahead and say this guy here they know he's O negative. And so they go over and they just take a unit directly out of him and go ahead and they can put it directly into the casualty or the patient that's injured on the battlefield. And he doesn't have to, it's already warm. They don't have to carry anything else. He is the walking blood bank. He is carrying the blood in his veins. And they can administer it directly from him to another person. Now, again, this is a very controlled environment. They're very controlled with vaccines that they get. But it's just very, very interesting and just fascinating. And they've seen a lot of great success with this in the field. For those that aren't necessarily doing that person-to-person transfusion, the military is very strongly recommending, and a lot of these units are carrying whole blood products, O negative whole blood products, and they're able to carry them out in the field, at least in their vehicles, in helicopters and things like that. So seeing a lot of good research and good use of whole blood happening out in the battlefield in the military. So that concludes the presentation portion on the PowerPoint. So this is where I would ask if there's any questions if we're in the class, but unfortunately there's not. But if you have some, you can comment on the video below here. And then we're going to jump into the actual skills practical of administering blood. All right. Hey there, guys. Aaron Brocious again for our final presentation for the Johnson Community College Instructor Methodology class. So I suppose this will actually be the last time I talk to you guys, since this is the end of my final presentation here. So my presentation, as you just watched as I presented the PowerPoint, was about blood administration, and particularly pre-hospital blood administration. So we came outside. Obviously, we can't teach this in class like we were supposed to, so bear with me as I kind of had to make do with what I have to present, kind of teach how you would actually, the application of administering blood, okay? So as we learned from the PowerPoint, from the presentation, so for us to administer blood, whether we're on a helicopter, whether we're on an ambulance, like some departments are doing in 911 systems, we're going to obviously either have a trauma patient, they've got penetrating or blunt trauma, or a medical patient, and at that point we're looking into their hemoglobin. So they've met one of those criteria, and now they have a heart rate greater than 120, a systolic blood pressure less than 90. Those are, especially with trauma patients, going to be the biggest things that we're looking for, okay? And then some signs of hemorrhage. So our patient has met that criteria. So now we need to make sure that we get the right equipment and that we do the right process, because this is a very, it's simple, but it can be dangerous if it's not, if the process isn't followed appropriately. So first thing we want to do is make sure that I have a second provider. So for almost any protocols in any department, I need to have a second provider. So a second medic, whether that's a supervisor, another medic unit, a second medic that can verify with me the blood, the patient, all of our rights for administration, okay? So for the sake of demonstration, my wonderful sister-in-law, Jade, who is behind the phone and the camera here, is my assistant, and she's also going to be my second provider. So I do have two providers on scene, okay? And also thank you for your assistance. So then I've got two providers. Now I need to make sure I have the right equipment. So what I do have, and I'll show you, is I've got my blood tubing. So this is our Y blood tubing, and I'll pull it out and kind of show you how that is set up. We've got our normal saline. This is our clear bag of normal saline. These are small demonstration models, if you will. So I obviously couldn't get all the full-size stuff. And then we have our blood, okay? And we'll talk a little bit about that, but we have our blood product there. What I don't have for demonstration purposes is an IV catheter in a person or a mannequin or anything like that. And I don't have a fluid warmer, which is what we would want as well, because this blood, as we talked about, is going to be stored in a cooler, something to keep it cold so it does store longer, okay? So you want that IV catheter, which was 20 or larger, so 20, 18, 16, or 14 gauge IV catheter. And that fluid warmer, there's a bunch of different brands, and we talked about a few of those. So I don't have those, but for the rest of the demonstration, we'll be able to at least talk through the basics of this. So the first thing that we want to do is I'm going to go ahead and hang my fluid. So I've got my makeshift IV pole here. So I'm going to go ahead and hang my saline. Now, as we talked briefly about in the presentation, the reason that we use normal saline and not lactated ringers. So a lot of our trucks, we carry both of those. So the primary reason is, in fact, that the lactated ringers actually contains calcium in the solution itself. And so that calcium can interact with the citrate in the blood that helps kind of store the blood. And that that calcium, if it mixes with the blood in the tubing, can actually cause the blood to start clotting in the blood tubing. Now, if we're giving this to our patient and it starts clotting in the body, that's actually not a bad thing because these patients are bleeding. So we do want to encourage clotting. But what we don't want is those clots to start occurring in the tubing, in the filters of the blood tubing, because then we're actually going to inhibit the administration of that blood to the patient, okay? So that is the main reason that we're using normal saline instead of lactated ringers, okay? So I hang my saline. I'm gonna go ahead and get out my blood tubing, okay? And I'll show you guys the blood tubing here. Let's go ahead. So the blood tubing, as we open it up, as you saw in some of the pictures from the PowerPoint, but we'll be able to see it a little bit better here. So we have a Y tubing. These do not have the normal drip chambers that you're used to in regular IV tubing that we carry on the trucks. So this drip chamber and filter is where all of that is going to happen. So I've got my Y tubing. I've got clamps. I'm going to go ahead and turn these clamps off. I want all of my clamps off before I start any administration of the product, okay? My clamps are good. My tubing is good. My chamber, I don't have any holes. My filter is intact. Now this is that 170 to 200 plus micron filter that we need to use for blood administration to get out any of those small particulates, okay? And then we have the rest of our tubing and our final clamp before we get to the patient side of the tubing down here, okay? So we do have on this tubing, we only have needle ports, so we don't have the twist-on ports like a lot of our IV tubing. But so at this point, our tubing's intact. We've been able to see, okay, we've got good filter, good tubing, our roller clamps, everything is shut off, okay? So the first thing that we're gonna do is we're going to prime the line, just like you're used to doing with just a regular IV tubing, normal saline, LR, whatever you're using. We're gonna prime the line with the saline, okay? Reason we're gonna do this first is so that we don't waste blood, okay? And you'll kind of see how that also comes into effect at the end of the administration as well. So, because I don't want to flush this line with blood and just let, blood that is very important, very precious, just go out onto the floor of the ambulance or the ground, okay? I'm gonna prime it with saline and then put the blood in after, okay? So we'll go ahead and spike the saline. Take it off here for a second. So, just gonna spike my bag. Hang it up. And at this point, I can open up this roller clamp for the saline, and I want to let it start filling my chamber here. So you can see it starting to fill my chamber. So now this is an important aspect of it, and I'll tell you why in just a second. Okay. So I've got the chamber, the bottom half of the blood tubing chamber is full, okay? And so this is important because now, once I attach my blood to the second arm of the Y, that blood, it needs to fall onto fluid, okay? I don't want that blood to fall onto the filter because if it falls and hits the filter directly, it can actually hemolyze the blood and it can actually hurt some of those red blood cells. It can actually damage the product before it even gets into the patient, which at that point is going to either be detrimental or just not beneficial to the patient, okay? So we just want to make sure our chamber is full of saline all the way up past the filter, okay? So at this point, this one actually has a safety ball, if you will. So it'll actually stop anything from hitting that filter directly. But once I got that floating and I know I'm up high enough, we know that we're full enough on saline, okay? So at that point, I can go ahead and just flush the rest of my tubing. Again, just like you do with any other blood or fluid administration, we're just going to flush our line. And there we go. All right, so I've got saline out the end. My line is primed. There's no more air in the line, no bubbles. Again, I'm going to go ahead and turn my clamps off, okay? Clamp is off to the saline. Clamp is off. Again, this isn't on the patient yet, but clamp is off to the distal end of our IV tubing, okay? So next thing I'm going to do, and again, I would do this with my partner, is I'm going to confirm my blood, okay? So in this case, for demonstration purposes, I actually have an O positive red blood cells, okay? So this is packed red blood cells, so this isn't whole blood, this isn't platelets, this isn't plasma. This is gonna be 1 unit of O positive packed red blood cells, okay? So I'm gonna confirm, depending on, if this is a transport situation, I'm gonna confirm that, I actually have a patient that can accept O positive. We know from the class that O negative is the universal donor. Reason being that there is no RH factor in the O negative blood. So most of your programs that carry just generic trauma blood products are carrying O negative, because I can give that to really just anybody. And I'm not gonna be too concerned about some type of transfusion reaction, okay? So, but for the sake of this demonstration, this is O positive packed red blood cells, okay? So I'm confirming that it's in date, I'm checking my date, I'm checking, the right patient. Obviously, if they're in the back of my truck, they're probably the right patient. I'm checking that this is the right medication or blood that I want to administer. I didn't grab the wrong bag or the wrong, blood type. So I've got O positive, packed red blood cells. It's in date. I'm confirming my patient. I'm confirming again that they meet the criteria: blood pressure, heart rate, whether they're trauma or medical. And then if I have access, I am confirming with labs. I'm looking at hemoglobin. I'm looking at hematocrit, okay? So confirmed with the patient or by my second provider. So then I'm gonna go ahead and I can hang my blood. So once the blood is hung, this is where it can get a little tricky just because we have a lot more moving parts here, okay? Most of us are not used to having to spike 2 bags on the same line, all right? So again, I'm gonna go ahead and remove my cap. I'm going to spike my bag. All right. So obviously, just like we see, this chamber, this line does still have air in it. So I need to flush that, but that is why we have the saline already filling this up, okay? So again, I'm going to confirm, and this is where I can go ahead and attach my line to the patient, okay? So I'm not gonna be taking any air. I've got both products spiked on both ends of the bag. So I can go ahead and attach this to my patient through that 20 or larger gauge IV. So we're gonna go ahead and attach this to the ground for this demonstration, but that's to the patient. So then, and this is important, I wanna keep the line for the saline turned off, okay? So reason being is if I start administering this blood, it can actually, in this small chamber up top, it can actually start mixing. And if I have both open, that blood can actually come back up this chamber. And if you've ever administered blood, you've probably made this mistake at least once, and you'll start getting blood in your saline bag, okay? And it just now looks like a mess, and it's not fun, okay? So to make sure that the clamp to the saline is off, and then I can open the clamp to the blood, okay? So I can start filling my blood. You can see it running down the line here, and it starts moving into my chamber, okay? So my blood line is primed. Then all I really have to do is open it up to the patient, okay? So coming down to my final clamp, and I'm gonna go ahead and start administering the blood. So you can see it start going in the filter. It's hitting saline. It's not hitting the actual filter, or the actual filter. So the initial administration is gonna be just the saline that was primed into the line. But then eventually we do see the blood starts to mix. We get the blood coming out, and now we see that we're administering blood. And we've got blood products. I can now titrate this back, okay? So with this administration, I've got the blood products going into the patient, okay? I'm just gonna go ahead and shut this off so we don't drain everything on the ground here. So a couple things that we want to keep in mind and be careful with. So even though I have checked my patient, I've checked my route, I've checked my line, I've checked all of those rights of administration, some patients can still have that transfusion reaction, an adverse reaction. So something that we did before that we already talked about in the presentation is we have that good baseline set of vital signs. Now that, you may have from first responders, you may take it yourself, but that first initial baseline set of vital signs is what I'm gonna use after administration to see, am I getting improvements in blood pressure? Am I getting improvements in heart rate, okay? The important vital sign that we don't always check on all of our patients that is good and necessary in this one is temperature, okay? So these patients, one of the first signs that we're going to see of a transfusion reaction is going to be an increase in temperature. It's the body starting to heat up, it's starting to say, something is not right. There's blood that is in my veins that is not cool. I don't like it, and so the body starts to heat up. You may start seeing a redness or a swelling in the area of the infusion at the IV site. If that happens, number one thing, first thing we're going to do, shut the blood off, okay? First thing we're doing is coming up here, and I am shutting off the blood. I don't want any more of that blood getting in there. If I need to take the actual IV out, I need to go ahead and do that, because I don't want it, if they're having a negative reaction to this blood, I want to go ahead and shut that off so they don't get any more, okay? So if everything's going well, we don't have redness, temperature checks are going well, I'm checking vital signs at least every 5 minutes, okay, for the first 15 minutes, depending on the, after 15 minutes, depending on the patient's severity, how critical they are, we may continue every 5. We may actually just go to every 10, 15, depending on, again, that patient's status. So if everything's going well, we're checking fluid or vital signs every 5 minutes for the first 15 minutes. If everything's good after 15 minutes, then I can continue that administration. Now, with some of our trauma patients, for example, you may think, and this is very true, that I need to get this blood in quick. They're bleeding out, their blood pressure's low, their heart rate's through the roof. I need to get this blood fast. I can't just sit here and wait for it to drip in through a 10-drop chamber here, right? So with that, once we have been through about that first 10 minutes or so, and we've given at least 50 mLs of blood, if there's no negative reaction, I can potentially squeeze that fluid in. So I can actually put a pressure bag on the blood. I've even seen, flight medics, flight nurses, guys actually just start squeezing the blood to get it in quickly, okay? Now, the big caveat with that is we want to make sure there is no negative reaction before we just start squeezing blood into the patient, okay? Once we've determined they're kind of past that window, we don't have that negative response, we can administer it a little faster if we need to, because this is a life-saving intervention at that point, okay? So, let's say, we've checked, patient's receiving the blood, everything's going well, this blood has been flushed in and we're almost empty, okay? The blood is running out in our fluid bag here. Another reason that we have the saline is, again, we have all this blood that's left over in the line, okay? And we don't want to just waste that and disconnect it and toss it in the trash, because, there's a good, 20 to 30 cc's of good packed red blood cells that are in this line, that we can still give to the patient. So once my blood is out and that's turned off, then I can open my saline back up and allow that saline, open it back up on both clamps, and then we can allow that saline, it's going to flush the remainder of the blood in that line, it's going to go ahead and flush it out, okay? So it's flushing out the blood that's in the chamber, in the filter. My bag is not quite big enough. You would have normally a liter bag of saline here. But it's going to continue to flush, and it's going to flush the line, and it's going to get all the rest of those blood cells and that blood that's in the line get to the patient, okay? So we're not wasting any blood, all right? And so really that's two of the biggest reasons for the saline is at the beginning to flush that line, and at the end to flush that line, again, to save the blood, okay? So once we've continued and we've got everything administered, then we can go ahead and obviously just disconnect it, just like we would do with anything. And if necessary, depending on our protocol, depending on the patient, what they need, I can spike another bag in this with the same bag of saline. I can spike another bag of packed red blood cells going through that same check process. If they need plasma, if I have whole blood, I can go ahead and administer that as well, okay? And then once we're done, we're just going to continue to monitor our patient and hopefully get them, if they're needing blood from us right now, they're probably needing an OR somewhere so they can stop this bleeding, okay? And then once we get them there, just give your report and then just documentation. Documentation is very important, like we know with any patient, but with blood administration, it's tracked by Red Cross, blood banks, everything. So we want to make sure that we document, what kind of blood was given, how much of the blood was given, was any of the blood wasted, things like that. So it's just another aspect of our documentation, which should already be pretty thorough, okay? So hopefully you guys learned something from that, enjoyed the presentation, enjoyed the demonstration, and I look forward to seeing you guys out in the field at some point. And thank you guys, I appreciate it very much.
All right, and so that concludes my presentation here.
I'm looking at almost 44 minutes and 45 seconds, so just shy of my 45, but I will be attaching the quiz to go along with this video, and I put it in the discussion board there. I hope you guys learned something from that and maybe have some takeaways of something that maybe you didn't know before. So hope you enjoyed it, and again, like I said, I look forward to seeing you guys out there, and best of luck to everybody with teaching and with your careers in EMS. And I'll see you guys around.